I work in Colorado, which is the American equivalent of Alberta. And we've got mountains and we've got plains, and a glorious place. So we've been working with psychedelics for quite a number of years now, and it's kind of an interesting crossroads that we're at, because we treated our last patient in the MDMA trial last week, and this was a crossover patient, and we're about to wrap up totally with MAPS. About a month ago, we published our phase 3 results in Nature Medicine, which, as you know, is a very prestigious medicine in healthcare. And the results are pretty astounding. But I'll just give you a little segue about my sort of run with this. I got exposed and learned about the value of MDMA during medical school in the late 70s and early 80s with Andrew Weil, who was very connected to the national scene about sort of the emerging psychedelic medicine perspective. And following graduation from medical school and a little bit of time in Cooperstown, a shout out to my friends watching from Cooperstown here, practiced with MDMA in a rural area in Arizona as a general practitioner for a number of years before it was scheduled in 1986 by the DEA. And I had some dialogue with Rick Doblin in the late 80s and looked to see if we could get some research started, but it was really just not the time for that, and sort of moved away from psychedelics for a while. But then somewhere around 2000, 2012, heard that they were doing phase 2 trials in Boulder, and reached out, got involved in the phase 2 trial at our clinic. And for the last 7 years, we've been doing phase 2 and phase 3 trials with MDMA. And so it's really full circle, and really committed to the psychedelic paradigm. And we've been working with LSD. We've been obviously working with ketamine for the last 8 or 10 years, and about to step into 5-methoxy-DMT work at our clinic, which is exciting. And because of Proposition 122 in Colorado, we now have the ability to start working with psilocybin, which has been a very exciting. So it's this sort of psychedelic paradigm has come along much faster and much more broadly than I would have thought 5 years ago. It's really accelerating. So what I'd like to do tonight is to talk with you about the results of our trial, talk to you a little bit about the way the research looked, what the results show, and then begin to look a little more into the future about where MAPS is going, what the submission to the FDA looks like, what the time frame is, and what we might expect over the next few years for the rollout of MDMA-assisted psychotherapy. So I guess the first piece is to really just be very clear that this is not a research study about MDMA. This is a research study about MDMA-assisted psychotherapy. So in the trial, everybody gets 45 hours of therapy with or without MDMA. They either get a placebo, a sugar pill, or they get MDMA. And in this trial, what it looks like is they have some screening. And I think we screened over 300 people to get 121 enrolled, and basically 94 completed the trial. And this is pretty consistent with our other work in psychedelics, is that we end up screening 3 or 4, sometimes 5 people to enroll one. And the reason that happens is people have exclusions. There's something that's gone on in their background that renders them excluded from the treatment, or they drop out for some reason, etc. So it's a cumbersome process, and that's why it took so long. Over the 7 years in the different phase 2 and phase 3 trials, we probably treated about 30 people total at our clinic. But just the amount of screening, the amount of monitoring, the amount of data collection that goes through with each one is really just considerable, and would probably blow your mind a little bit about the amount of data that each person has a 3-ring binder that's about this fat. Just really incredible. And what the process looks like is once they get screened in, then they have 3 prep visits where they meet with our therapists. Usually it's a team of 2. typically a male and female therapist. They meet with them for 60 to 90 minutes to get to know them, get to develop some rapport, some trust, and really try to make some connections, feel safe, understand what the program, the process really looks like. And then on their first experimental day, they will come in at about 9 in the morning. By 10 in the morning, they get dosed, and there's a 50-50 chance that they get MDMA or that they get a placebo. And then about 90 minutes in, they have the opportunity to take a supplemental dose, either a supplemental placebo or a supplemental MDMA dose. And the way the MDMA is dosed is the first time, in their first experimental day, they get 80 milligram dose, and they have the option of a 40 milligram booster. The second and third time, they get 120 milligrams with the opportunity to get a 60 milligram booster. And what the booster does is it doesn't make them go any deeper into the MDMA experience, but it just makes it longer. So we have a little bit more working space to work with them. And typically what that looks like is they start coming on and having an experience somewhere usually 40 to 60 minutes. And then for the next 3 to 4 to 5 hours, probably 4 to 5 hours, they're pretty deeply in the MDMA experience. And what's interesting is it's very difficult to blind this stuff. And even though it is a double-blind controlled study, so that the therapists don't know what people have gotten, they don't know what they've gotten, that about 94% of the people who got MDMA guessed correctly that I got MDMA. And I think about 65% of people that got placebo guess they got placebo. So it's very difficult to blind this, which makes the study, the research, all that much more difficult. But it's very difficult to blind psychedelic medicine subjects. It's even harder, as you might guess, to blind LSD patients. You sort of know whether you got a sugar pill or LSD, depending on whether the spider on the wall is talking to you, you know. Well, let's see. So what else can I tell you? Maybe what I'll do now is I'll segue. We'll go over some slides. I don't want to get too data heavy with this, but I want to give you a sense of what the data looks like. And then we can talk about the protocol itself and talk about some of the questions you might have. So after someone has their first MDMA session, they have 3 integration sessions after that. A month later, they have another MDMA experience, 3 more integration sessions. A month later, their 3rd session, more integration sessions, and then a termination visit. So it's very intensive. As I said, everybody gets 45 hours of therapy with 2 therapists. One of the implications of that is that it's going to be expensive. If you imagine that a therapist gets, let's just round it off and say $100 an hour. So you've got $200 an hour for 45 hours. That's $9,000 right there. And likely more than that, depending where you live. And then you have to throw in the cost of the medicine, the cost of the facility, cost of screening and blood work. So people are estimating that this treatment will cost $15,000. But if we can get the results that we got and really provide what looks to be a potential cure for PTSD, then it's likely to be worth it, because PTSD is a devastating illness where people are not able to work. They're high utilizers of the healthcare system, and they may cost people $100,000 to $200,000 over the course of their illness. So there's value in really treating this well. Let's see. So let me share my screen. And okay. All right. Are you seeing that okay? Great. Excellent. All right. So the way these things work, when you're trying to get a drug approved by the FDA, you have to have 2 large phase 3 trials that give evidence that it's safe and effective. Phase 2 studies are smaller studies, and they're looking at dosing, they're looking at safety, but they're not large enough to prove that it's effective. And to give you an idea, that it typically costs $100 to $200 million to bring a drug through phase 2 and phase 3 trials. And MAPS, the sponsor of this study, the Multidisciplinary Association for Psychedelic Studies, has done this all by donation. This is not a big pharma company. So it's pretty unique in that way. Well, let me step in. So this is the study itself that was published a month ago, 9/14, in Nature Medicine. So MDMA-assisted therapy for moderate to severe PTSD, which is a randomized, placebo-controlled phase 3 trial. As you can see, there were a lot of authors on this. I'm really proud to have my name attached to this landmark study, because I do think that it's going to change mental health care and move us into a psychedelic paradigm and out of a suppressive paradigm in mental health, where we're using antipsychotics, antidepressants, anti-anxiety agents, but not really curing anyone. We're managing misery, and I think we need to do better than that in healthcare. So these are some of the characteristics, and as you can see, the average age, 38 to 40, average ethnicity. We're really proud of this study in that we had 37% or 33% of the people who identified as other than Caucasian. So one of the real criticisms of psychedelic work is it's been very Anglo, very Caucasian. And we made a big effort to recruit a more diverse population, and I think we were pretty successful. What else can you see? So if you look down here, trauma history, and you can see that 92% of people in the MDMA group had a developmental trauma. In other words, they had childhood physical, sexual, or emotional abuse. 17% had combat exposure, 17% were veterans, 75% had multiple traumatic events. So often what we saw in these severe, moderate to severe PTSD is they often had childhood trauma and then adult trauma layered on top of it. So they were abused growing up, and then they were raped or had a battlefield experience or an IED that blew up or whatever the case may be. So we're dealing with people with very severe PTSD. And in this study, this MAP2 study, 75% of people had severe PTSD. So that's really significant. On average, these people suffered for 16 years with severe PTSD. That's a long time to suffer. They often failed 5 or 10 different medication trials and may have failed 3 to 5, maybe more episodes of psychotherapy with no benefit to them. So these are the results right here. Primary endpoint was the change in the CAPS score. So the CAPS is our best measure of PTSD. And what you see on the blue line is that everyone started out roughly around 40, which is pretty severe PTSD. And then on the bottom axis, you see after session 1, after session 2, and after session 3. So what you see is more and more separation between the two different groups. And so what's interesting is that the people who got placebo actually got better too. They were getting 45 hours of therapy in a couple months. So that's very intensive therapy, and it helped them. But it didn't help them near as much as the group that got MDMA. And I've got to tell you that one of the real miseries of doing this research is working with people with severe PTSD who got a placebo, who've been taken off all their psych meds, and then having to sit with them for 6 to 8 hours and talk about their trauma. It's just very painful to watch, very painful to experience, obviously, and not our favorite part of the research. On the other hand, When we could see that there was a little glow in their eyes or dilated pupils, we knew that we might be working with someone on the medicine. And that was just a joy because they are able to go in and re-experience their trauma. Now, this is not a pleasant experience, and it belies the name ecstasy given to this process, but they're able to go through and experience their trauma fully, but without. What happens with PTSD is that when people get close to dealing with their trauma, they short circuit into stress, anxiety, just pure terror. Their system is overwhelmed, they shut down, it's terror, they can't process, they can't digest it. But with MDMA, they feel safe and they're able to go back, work through the trauma, see that it's not going to happen to them again, things are different. They're able to re-experience it, digest it, and begin to put it behind them. Now, what's interesting is that you and I, if we have a traumatic event, a car almost hits us, something happens, we're often stressed, maybe mildly traumatized, but over a period of days or weeks, we digest it and we get over it. But with PTSD, it seems to exceed the capacity of the brain, the body to handle it emotionally, and it just short circuits. A fuse is blown, and every time you get close to dealing with that, a fuse is blown. So, for example, someone who went to Iraq and was in a combat situation where they came close to death, if they're walking down the street and a car backfires, they're immediately thrown back into the trauma. They're immediately re-experiencing that. And it's just the pure horror for them. And what we showed in this trial is that people get better. For example, 86% of the people that got MDMA no longer qualify. They have a clinical, what we call a clinically meaningful response, 86%, and 71% no longer meet the criteria for PTSD. And the dropout rate for MDMA was about 2%, which compared to prolonged exposure or cognitive trauma work, where the dropout rates are 40, 50, 60%, that's pretty incredible. So we really have a treatment here that is remarkable. And the effect size that we've shown, which is sort of our best measure of how big the treatment effect is 2 to 3 times the effect size that we find with Prozac and Zoloft, Paxil, Zoloft, which are the two things that actually have been proven as SSRIs to be helpful. And what's interesting is SSRIs have a very limited benefit, and that decays over time. So the improvement at 6 months is not near as good as it is at 3 months, and at a year, there's hardly any improvement at all. Now, what's interesting with MDMA is people have 3 encounters with MDMA in their treatment, and a year later, even more of them are better than they were a couple months afterwards. They continue to improve. And I think the reason for that is they're continuing to digest their trauma and work through it in a natural way. They're getting over it. And that's really what we want to see with trauma. Let's see. Side effects were really pretty minimal. And what we see with side effects is, you can see it here, muscle tightness, nausea, decreased appetite, feeling hot, feeling cold, sometimes at the same time, which is tough to record. Paresthesias, which are a sense of like numbness, tingling, needles on the skin, chest discomfort, dry mouth. And they didn't really limit it. The most significant side effect we would see would be palpitations, which is a sense of your heart racing. And that occurred in about 9% of people. So not a significant problem there at all. So you can look over this list, and these are pretty mild things. And on the left is with the MDMA, and on the right is with placebo. So these things obviously occur a little more often with the MDMA, but they still occur, many of them, with the placebo. Yeah, so 45% of people experience some nausea, transient, compared to 21% with the placebo. So it's a real medicine. It's significant. We think we compare it roughly to taking Ritalin. You probably know kids that are taking a stimulant or adults. It's roughly like taking 20 milligrams of Ritalin. It's an amphetamine-related compound. It tends to increase your blood pressure, increase your heart rate. You're aroused, but what's interesting is it's not a psychedelic. People have no sense of sensory distortions. They don't feel like they're losing control. It's not like taking LSD or psilocybin. It's technically closer to taking a stimulant. Probably the closest thing that you could imagine is if you drank a couple cups of strong coffee, that the effects would be similar. Your heart might pound a little bit, your muscles might be a little tense, and you wouldn't have much appetite. So those things are pretty consistent across the board. Now, what's interesting is that we didn't really have any serious unexpected events, no deaths with MDMA. But yet when MDMA is out in the real world as Molly and ecstasy, people die. And they die because they're not under medical supervision. They may be taking doses that are really unreasonable. For example, people get in ours at the highest level 180 milligrams of MDMA in a day. Whereas out in the rave world and the Burning Man world, people may be taking 500 milligrams. And people will die with that amount of medicine. And people do die. And I think in England, they have recorded 30, 50, 60, 80 deaths per year from MDMA. But you compare it with how many doses are being taken. We can't even really estimate, but probably tens of millions of doses of Molly and ecstasy are taken per year, tens of millions of doses. So it's pretty common out there. I think I'm going to segue out of this, stop the screen share. And maybe now we can just talk a little bit about, talked about the protocol. We could talk maybe a little bit about the difficulty of getting into training. So MDMA will likely be submitted as a new drug submission to the FDA in the next couple months by MAPS. Then the FDA has 1 to 2 months to respond with any questions or queries. Ultimately, they have to respond after that to 6 months and give a yay or nay. And if they give a thumbs up, which I think our data is really what we might say is a slam dunk, but I don't think you want to go on record with the FDA and say that. But they've approved Paxil and Zoloft with much, much weaker results than we've shown. So we think we have a very good chance of being approved. And then it's a question about what is the FDA going to require of us? Are they going to require an overnight stay? Are they going to require 2 therapists in the room? MAPS has the ability to control how this is released and rolled out commercially. And that may occur, it's likely to occur last quarter of next year and into early 26 or 25. That would be 25. And they may have requirements. They're likely to only require people who've been certified by MAPS to provide this care. So you have to go through a MAPS training program as a prescriber or as a therapist to be approved for this care. That is very likely. And then it's possible that the FDA will require an overnight stay. We're hoping they don't. And MDMA will only be used in certified centers. No one will ever be given MDMA to go home with. So hopefully that is very clear. So no one will ever go home with MDMA, at least in this medicalization process. It'll probably be mainly used for people with PTSD. We're likely to go off label at some point and start being able to use it for other things. But I think at first, the FDA and MAPS are likely to keep that pretty well controlled. To get trained by MAPS is a process. So I think about 2,500 to 3,000 people have been trained in MDMA therapy, all but clinical care, and only about 1 to 200 people have been trained in the clinical care of MDMA, just because this is only being done in trials. So that's a very limited opportunity. So you can go through, there are a number of programs that have connected with MAPS to provide this training and roll it out. But the real bottleneck comes in to be fully approved by MAPS, you have to go through and treat 1 to 2 patients where you're supervised. And I've been trained as a supervisor for MAPS. And so the challenge is getting enough opportunities where we can do that. And right now, no one is being given MDMA in our phase 3 trial any longer. So there's really very limited opportunity. So once it's approved and legalized, then we'll again have an opportunity to get people fully certified by MAPS. But it is a difficult, cumbersome, and somewhat expensive process to go through and get trained. Well, that's a bit of an overview. You see, I'm about a half an hour. And I thought what I might do is just jump into Q&A, dialogue, questions, thoughts people have.
Absolutely. If you click on the bottom of your Zoom screen under reactions, there's an option for you to raise your hand. It's a little yellow hand that pops up in your screen. I think that we are able to, with the numbers we have tonight, to actually have people ask a question themselves. You are certainly welcome to pop that into the chat box as well, any questions you might have. If you're curious about how this might impact you in your practice, I've noticed from where people are coming from, there are some from the US. I think there might be a couple from off of the North America altogether, and as well in Canada. I'm not seeing any questions right now, so maybe I have a couple here. What is the impact here in Canada with this? I know that obviously MAPS is US based. It's working with the FDA in the US. What do you see happening for Canada? I might actually pull Vu into this question as well after you answer, Scott.
Well, I think Canada is a different beast. Canada is not something I know that much about, and much of what I learned from talking to Vu over the past few weeks. So maybe we want to segue to having Vu answer, but it is a dialogue with Health Canada, the equivalent of the FDA, and just trying to get and to meet their approval process. So Vu, I'm going to hand that one to you.
Yeah, you want to answer that one?
I do know that Health Canada has a very different approach than the FDA. However, I guess the big question is, does MAPS have the intention to come into Canada to go after that drug identification number for MDMA, or will they be working in the US, which seems like what their focus is right now? And if that's the case, then it might take a drug supplier in Canada or someone else to run duplicate clinical trials up here in order to get Health Canada to approve it for a notice of compliance. So I guess that's a question to you, Scott, is does MAPS have any plans to come up to Canada to apply for the DIN up here?
I would assume they do. I know they're pursuing Europe and European Union pretty strongly with a phase 3 trial over there. My sense is they're focused on getting the football over the goal line with the FDA first as their main priority. And I know they're pretty much 100% focused on that. But I would be very surprised if they are going to ignore Canada. It's a significant market. And Canadian people are just very nice, so they just ought to do it, right?
So, and I also know that in Canada, they might not hold the prescribing to the rigor of the FDA based on the clinical trials. So, would MAPS, I guess, insist that they hold it to the rigor that the FDA would, or would they be flexible and say that in Canada they're open to being flexible with the protocols that's perhaps a little bit overdone in the US?
Yeah, I think Vu's question is about the intensity of this protocol with 45 hours, 19 visits spread over 5 months. It doesn't make it very amenable to rural populations. It doesn't make it very amenable to problems with distribution and access. So I would hope they would be more flexible, but I can't speak for them. And what's interesting is that I am an independent researcher working at a site. And basically the way it works is MAPS raises the money as the sponsor, and then they hire sites, in this case, 13 international sites. And they have to pay our therapists, they have to pay the investigators to go through and do this work. Because if, they're spending at least 20 to 30,000 on each participant who went through in just direct costs. And then they have to administer that, they have to collect the data, they have to, et cetera. So the cost of these trials is just enormous. And so from what I've understood from you, Vu, the requirements in Canada are more flexible. And I think MAPS will probably have a consideration about whether, if they were to simplify the Canadian protocol versus the American protocol, might that pull traffic out of America and bring it to Canada because it would be simpler or cheaper. So I think there's going to be a lot of concerns and discussions about this, but as I've spoken with you, it would be good to get into a dialogue with MAPS about this so we can understand it more directly.
Mm-hmm. Yes, we have a lot of questions popping into the chat box, so I do want to get to these. Alexandra, thank you so much for your question. She just actually had a simple clarification. What did you mean by cure? Does that name or that word ring a bell from what you were saying?
Sure. Well, we are talking about the possibility of a cure. Some people who've gone through our process with MDMA and trauma are, for all intents and purposes, cured. They no longer have symptoms. They don't have to take any medicine. They are done. They've digested their trauma and they've moved on. And what that reflects is the healing power of the body and the mind to digest this once we eliminate this barrier of over-arousal and terror that is caused by the PTSD. So we've definitely seen in our phase 2 and phase 3 trials, people whose CAP score went from 40 or 50 to 2 or 3. And basically, I probably have a higher CAP score than that. But no, joking aside, these are people who just are done. They're better. They're cured. And it's not like it's simple and it's just the medication. It is intense, painful, difficult therapy, and it's often protracted over time. But some people are cured by this process from what we've seen.
Well, that is great news. That is great news. Thank you for clarifying that. Thank you for Alexander for asking that question. Bonnie, I'm going to go to your question, or actually there's a couple questions here, and then Shane, I'm going to pop over to you in the live box there. Bonnie would like to learn more about other potential applications beyond PTSD. I mean, this could be a very large conversation, but maybe you can list a couple of options, and also what to learn more about the integration process between the MDMA medicine sessions. So there's a couple of questions there.
Yeah.
I'll let you just tackle those.
Well, first of all, MDMA looks to be a non-specific amplifier of the psychotherapeutic process. People feel more connected to their therapist. They feel more open. They feel safer. They are able to access more of their experiences. And they're just much less defended and much more flexible in their thinking. And so it's just an ideal medicine to amplify and speed psychotherapy. But what that basically means is it can help probably a lot of different things. We certainly have trials underway with eating disorders. We've had a trial published on autism issues. I think those are two of the areas that look to be most interesting. There's exploration going on with personality disorders, but I think there's just a lot of questions about there. What could this help? And these trials are in process or coming or proposed, but it may be years before we know that. And once MDMA is approved by the FDA, and we start to have some flexibility to go what's called off-label and use them for other problems, that may be a little bit restricted at first, but likely 2, 3, 5 years down the road, we should have more flexibility to do that. But it's certainly clear that it helps PTSD. It may help depression. It may help other forms of anxiety. It may help anorexia nervosa. It may help bulimia. It may help autism. So these are questions that we're wondering, and we think. The integration, the question, Natalie, around integration is critical because this is assisted psychotherapy. The medication assists us, and what we do with that psychotherapy is we're helping to take the experiences, the insights, the perceptions that are shifted and changed with MDMA, and then begin to help to integrate them and make them more enduring, make them more long-lasting, make them durable. Because for my mind, durability is the measure about how good these treatments are. Let's look out at a year. And I think that's where most psychiatric treatments fail, is they look pretty good at 3 and 6 weeks, but most of our current psychiatric medications really begin to fail at 1 and 2 and 3 years. They just don't hold up. And that's what we're seeing, and we think that psychedelic medicine can really offer us a very different model.
Yeah, I love those results you were saying where they were even better than the results following, the actual trial itself, the follow-up. That's such great news. Shane, go ahead and unmute and feel free to ask your question out loud. And other people are welcome to put up a hand if you want to ask your question yourself as well.
We're actually already sort of in the territory that I was curious about, which is to do with other trauma presentations besides, like, I think the stories that are often heard and what seems to be like a large part of the sample population is military and veteran trauma. But I'm wondering if you could say anything else about what you already are starting to do about other presentations of trauma, other like client histories and experiences that showed up in the trials and showed up among the population that you were interacting with here.
Yeah. So what we tried to recruit as many veterans as we could, and when we actually have pretty good numbers. I think it was 17% of our enrolled population were veterans. So we've got some numbers to look at. I know the VA is deeply interested. They're starting to roll out their own trials. The American Veterans Administration starting to roll out their own trials with MDMA before they approve it in their system. But generally what we found is if people have limited trauma, 1, 2, or 3 episodes is typically all they need. A single incident trauma, if that's all you've got, if it's a natural catastrophe or a rape or an assault, that seems to be pretty easy to work through in our 3-session model. Where we ran into challenges, and often what we saw in these folks, is they have developmental trauma, and then they have adult multiple incident trauma layered on top of it. And so we're dealing with layers of an onion. And sometimes after 3 sessions with MDMA, it's clear that people have not done all they need to do. And so we hope to have the ability to do more sessions post-approval, post-rescheduling. And so someone with very, very severe trauma, for example, developmental trauma layered on top of, military trauma, combat trauma, that we might need 6 sessions to deal with that effectively. Because what we're seeing is often what's interesting is people will say, I've got a rape, I've got combat trauma, I've got an assault. That's what brings them in. But when we get them in and start working with them with MDMA, typically the first session goes back to 3 years of age, 5 years of age, and we're working through their developmental trauma, their attachment trauma. I mean, I'm trained as a child adolescent psychiatrist too. And what's interesting is, the first session is almost like you're dealing with childhood issues and often very childlike behavior in the session from people as they regress back to the date and time of their trauma. So it's remarkable, but a lot of it has to do with the amount of layers, the amount of chronicity, the amount of just the amount of trauma load that people have, and it really varies enormously. Hopefully that was helpful, Shane, trying to understand that, but it does seem to be pretty effective for dealing with combat trauma.
Yeah, very helpful. Thank you very much.
Oh. Thank you, Shane, for speaking up. I have a couple of questions here in regards directly to the trial. Wondering if any of the patients were actually on SSRIs, or was that basically they wouldn't be able to be on those during your trial?
So people could enroll on an SSRI, but we'd have to taper them off their medicine. They can't be on any serotonergic. Basically, we had to take people off all their psychiatric medication with very few exclusions. And that is a challenge. People have been on psych meds for 10 to 20 years. It can take months to get them off if we can do it. And many people who've been on meds that long just simply cannot do it. So that is a big challenge. And it is one of the harder parts of doing this research, of trying to find people who are either on minimal meds or have the ability to get off their medications.
Yeah. One quick question about the cost. I was going to throw this in before we went into another question. The 100 to 200 million, how is that spent? Are there people that are recipients? I know it's a nonprofit, so I can't imagine that any money of this is going to waste anywhere, but maybe you can just explain that a little further.
Well, the phase 3 trial itself, I think cost, let's just round it off at $100 million. So $100 million goes to administer the sponsor, to do all their researchers, to do all the data collection. And then it goes to hiring the sites. For example, at our clinic, we have to dedicate rooms to this. We have to dedicate therapist time, practitioner time, and that ends up being a good chunk of money. And basically, we're not paid for results. We're not paid anything beyond our sort of hourly commitment. And what's interesting is that most people were working at some fraction of their regular clinical pay. I got paid probably 30 cents on the dollar compared to what I do in my normal work. We actually refer to this as glorified volunteer work. And it's because we're passionate about the work, we're deeply committed to it. But it's one reason why MAPS was able to do this maybe for under $100 million instead of $200 or $300 million, and that nobody was getting fat off this anywhere in the system. It was a pretty lean operation. And it really just speaks about the complexity of having 13 sites across the world doing complicated research with intensive visits and a lot of data collection. It's just hard to do, and it takes a lot of personnel.
Mm-hmm. Thank you. That's a great explanation of that. Some of us don't know how to wrap our head around $100 million, but when you start parsing that out for all that MAPS has been doing, that makes a lot of sense.
And you think that it's been spread over 6 years.
Exactly.
So think about that too.
Exactly. Thank you. Thank you for that explanation. I know that'll satisfy a few people probably have questions. Seth, I see you're the next question here in the chat, and then I also see you with your hand up. Would you prefer me to read your question, or do you want to ask out loud?
So the question is separate from, I raised my hand to go back to what Shane was asking,
Oh, sure.
and I put in another comment or a link to a very interesting little segment that the secretary of the VA or the head of the clinical part of the VA, had a discussion with a veteran who was treated with, actually, I believe, I forget if it was psilocybin or MDMA. And the veteran, and this is 2015, and he is fascinating and much more articulate than the researcher and the physician who are also on this special podcast. He's early in the podcast, and what he says about the effect of the protocol from your protocol is remarkable.
I think it is MDMA. And actually, what I'd like to do when it's time to end is I'd like to end with some quotes from some of the participants who went through our treatment, and some of them are veterans. So,
Perfect.
So, I mean, this guy has a great memorable quote also.
Mm-hmm.
Thank you.
So I would encourage you, if you scroll down, don't watch it now, obviously, because you're here, but you can't copy paste out of the chat box. So just click on that and then save it if you are interested in having a look at that later. You can go ahead and do that. There was one other question from Seth. Some therapists, many therapists are already providing MDMA-assisted treatment. Maybe you want to clarify in what context. Won't that continue even if MDMA is approved? So I'm guessing he's thinking underground. If certification is required, won't that slow access to people who want treatment? These are really, really important questions to ask, and maybe you can address that. I know coming from a clinical trial where it's very clean, but there's a whole lot of questions about how this is going to roll out. Maybe you could, do you want to tap on that?
It may be useful to divide up basically psychedelic medicine, MDMA work, and there's three paths that are going forward with a lot of these psychedelics right now. One path is medicalization right now. And so with medicalization, what we're trying to do is give healthcare providers the ability to prescribe and engage in this treatment, theoretically with the ability to do it with licensed people in licensed settings with healthcare reimbursement. That is the goal for all this. And for example, in the US, if we can do that, we bring access to 150 to 200 million people in that medicalization process. Separate from this, there's another track that is either decrim or underground. And these are therapists that are doing this with like psilocybin, it's decrim, but with MDMA, it would be underground. And basically they're doing it, somewhat askance of the law. They're often doing it at some discount because it's not licensed and it's not above board. There's no reimbursement. But and then finally, the final path, which is interesting, is religious freedom. So there's now over 20 psychedelic churches in Austin, Texas, among other places. We've got quite a few in Denver. So this religious freedom, the ability to say, this is part of my church, this is the way I want to practice my religion, and this is important to me spiritually. So we have these three different paths, but really the path that I know most about and the path I've been focused on is medicalization. And that's really in licensed healthcare settings with licensed people with the ability to get insurance reimbursement.
And that for accessibility and for safety in that kind of mass, that it's definitely a great approach. That just sounds like a feasible. I mean, I don't know how feasible at this moment. We try to wrap our brain around what we can offer with that, but boy, that just thank you. I just want to say thank you to you and to MAPS for pushing so hard for honestly for this accessibility to get to reach that help.
I think these three different settings offer different things to different people. They're different price points, and they serve different needs. So if you have a geriatric patient who's not connected to an underground therapist or doesn't want to go into a religious setting, medicalization is right for them. But for other people, religious freedom or underground work maybe. And so I'm sort of all paths. Let's raise all boats here.
Oh, I like that. Thank you, Scott, for qualifying that. That's going to speak to everybody on different levels in this room. So I really appreciate that. I know in Canada we do have, I think, 4 ayahuasca churches that have been sanctioned by Health Canada as well. So it is a real thing, and valuable for people who are participating in those settings. That probably covers here. Bonnie, I think that question covered what you were looking for here. I don't think there's any big questions on insurance companies at this point, but obviously that is the push towards having that accessible through that. What is the capacity of supporting those with addictions issues, potential contraindications when we're talking about addictions? Is MDMA a good match? There's some other psychedelics that are great matches for addiction. What do you think about for MDMA?
I think there's some studies that are just kicking off looking at MDMA and addictive behavior. I think it's less clear. Like you said, I think that psilocybin and even ketamine, I think may have more potential there. And we're actually using ketamine in our office for treating addictive issues.
Yes.
It's unclear whether MDMA offers a benefit. And so I think it's a big question mark for us right now.
Okay, thank you. There's a few other questions in here. Is there a need for resourcing prior to MDMA treatment?
For those of you that resourcing is bringing added resources, like the name implies, to people who are doing trauma work, like with EMDR, resourcing is, getting grounded, a safe place, a beautiful place that you can go and get some resilience and resources from. MDMA is the ultimate resourcer. That's one way to think about it, is that people with MDMA don't need any more resourcing. They've got it. It's there. It's much better than what can be done without MDMA.
Mm-hmm. Thank you. That's great. We have more questions here than we have, I think, have time for. I know I want to give a little shout out to Vu, or offering for Vu to say something. And I know we do want to end with a few of the quotes, as you have suggested, or that you would like to do with this. I know that maybe Vu will allude to this, but Dr. Scott Shannon is going to be coming on as a instructor with the Atma training program. And so you will be able to dive deeper into the protocols and what this looks like from a variety of angles. I think not just the MAPS protocol, but how do we begin to work with this maybe outside of the clinical setting as well, in that context. If you're interested, I know you're here, you're seeing what Atma is doing with psychedelic-assisted therapy, psychedelic-assisted therapy training. If you're interested in what we have to offer, maybe more of diving into some of the studies with Dr. Scott Shannon in our coming semester, please give Tabitha a message. She's there. She'll give you email training@atmajourney.com. We'd be happy to talk to you about what that could look like for you, and how that might help in your practice. If that is of interest to you, we have students from around the globe that are taking our programming. So I'm going to leave this with you, Scott. We're going to wrap up with these great quotes from the subjects from this trial.
Okay. Now I have a map of the battlefield. I felt deeply connected to painful feelings of the traumas as I saw them go by in spheres, but it didn't cause anxiety. I felt deep sadness in my heart, but also deep happiness that I was healing it and letting it go. And maybe one more.
Mm-hmm.
A whole deeper level of consciousness, calmer peacefulness. I don't remember ever having this. My mind has never been at peace like this. So these are the quotes, and these are just really a reflection of someone really stepping into their own healing. And this is the body, the mind healing itself when we take the barriers to healing out of the way. So that's one of the beauties of MDMA, why it's been so rewarding for me to be a part of this process. And hopefully this has been helpful to you tonight. So I'm appreciative of the opportunity and appreciate the connection.